We should start.
Yes, sir.
Okay, I think we can start. Good evening, everyone. I welcome you all on this auspicious day of New Year for many of the people celebrating festival of Diwali this time. And I really appreciate people who have sincerely joined this session. And many of the other people may be expected in few minutes. So I think we would not wait further. It is a very common problem that we are catering to, oxygen in preterms. So welcome Dr. Nilesh for presenting. You may start, please.
Good evening, everyone. So today we are presenting a journal. I am Dr. Nilesh Sadhwani, second year DM resident in GMC Aurangabad. The moderator for today is Dr. Amol Joshi. He is an associate professor in Department of Neonatology, GMC Aurangabad. So the topic for today's journal is the effect of automated oxygen control on clinical outcome in preterm infants. A pre and post implementation cohort study. Study was done by Salvarda et al. The place of the study was NICU of Leiden University Medical Center. The journal was published in European Journal of Pediatrics in February 2021. Design of the study was retrospective observational cohort study. The authors have obtained ethical clearance from Ethical Board of Leiden University of Medical Center. One of the authors had received a research grant from SLE Limited. The University of Tasmania and Royal Hobart Hospital have a patent concerning the automated control of inspired oxygen in newborn infants and have a licensing agreement with SLE Limited in relation to automated oxygen control software. So coming to the study, so what is the purpose of this study? Since the preterm newborns receive respiratory support, which includes supplemental oxygen, with the aim of keeping the SpO2 target within 90 to 95%, and preventing hypoxia and hyperoxia both. So, there have been observed a frequent and prolonged SpO2 deviation in these infants. And these SpO2 deviations have been associated with mortality, prematurity related morbidities like ROP, PVL, NEC, BPD, and neurodevelopmental impairment. So hence there is a need to titrate the FiO2 to keep the SpO2 in target range. However, the problems in keeping the SpO2 in the target range are lack of knowledge in the staff, concerned staff, low compliance, and high workload of the concerned staff. So the continuous oxygen titration is can be accomplished by automated oxygen control device, which aims to mitigate all these problems and improve the SpO2 targeting while reducing the bedside workload. During the AOC, that is automated oxygen control, signals from the pulse oximeter are being continuously input to the computer algorithm, which determines the adjustment to the FiO2, which determines and make adjustments to the FiO2 and give necessary feedback on oxygenation. The changes to the FiO2 are sent automatically within the ventilator or any other respiratory support device. Studies which was done by another group in 2014 had suggested that effect of AOC on oxygenation saturation over 24-hour periods had a beneficial effects, with infants spending more time in the targeted range, and there were decreased episodes of hypoxia and hyperoxia in these infants. So the aim of the study was to compare manual oxygen control with AOC and its effects on clinical outcome, and thereby assessing the effect of implementation of AOC, that is automated oxygenation control, as a standard of care in the outcomes of preterm infants during their admission. Coming to the PCOT, The population studied was preterms admitted to NICU in the group of gestation between 24 to 29 weeks of gestation. Intervention done was giving automated oxygen control for target range saturation as a standard of care. Comparison group was a historical cohort who had received a manual FiO2 titration. This group was studied between May 2012 to December 2015. The outcome of interest under study was mortality until 1 month after corrected term age, NEC, which was defined according to the Bell staging, PVL, which was defined according to D-virus classification, ROP, which was defined as per ETROP study classification, and IVH, which was defined as per, which was classified as per Pape's adopted classification. BPD was studied at 36 weeks of postmenstrual age and was classified as per NICHD 2000 consensus. The time frame of the study was between 1st May 2012 to 31st December 2018. Coming to methodology, we have discussed the inclusion criteria, which were 24 to 29 week gestational age preterms between 2012 to 2008 in LUMC tertiary care NICU. Exclusion patient, they had excluded patients who were admitted after 24 hours of birth, had major congenital anomalies, and did not require any respiratory support. Coming to the methodology, the pre-implementation cohort actually consisted of infants admitted between 2012 to 2015 and received manual FiO2 titration from the bedside staff according to the local guidelines. The post-implementation cohort comprised of infants between October 2015 to December 2018. The period, there was a 4-month washout period in between them. The ventilator used for respiratory support in the majority of the study period was AVIA ventilator, which used Cly O2 TM algorithm. In 2018, however, they switched to SLE 6000 as a standard of care ventilator, which used VDL 1.1 algorithm built in as an oxygen option. The data for the study was presented as mean, median, and the percentage as appropriate with standard test for normality. Statistical comparison was performed using independent t-test, Manny-Whitney U-test, and chi-square or Fisher-Isaac test. Coming to individual tests, the independent t-test. This test is used to check whether there is a difference between two independent samples. Example, difference between salary of men and women. The test is made up of independent persons and measurements. Specific prerequisites for this test are, there is an independent variable. Example, we can take for gender, which has 2 characteristics or groups, male and female. These groups should be compared in the analysis. Value in one sample must not influence the value in other sample. Hence, the 2 groups must be independent. The mean value of the sample must be calculated. Hence, this is only meaningful when the variable is interval scaled. For most accurate results, the variables must be normally distributed. Since the variance is needed for the test statistics, it must be same within the group. Coming to Manny-Whitney U-test, this test is used to compare 2 independent groups when the dependent variable is either ordinal or continuous, but not normal. It is a non-parametric alternative to independent t-test and allows you to draw different conclusions about your data depending on the assumptions you make on your data distribution. The example is to understand this, the example to understand Manny-Whitney U-test is you can discuss the attitudes of people towards pay discrimination. The attitudes are measured on ordinal scale, which differ on gender, your dependent variable would be attitudes towards pay discrimination, and your independent variable would be a gender, which has two groups, male and female. Coming to chi-square and Fisher-Isaac test, the chi-square test helps to determine whether there is a notable difference between the normal frequencies and the observed frequencies in one or more classes or categories. It gives the probability of independent variables. Chi-square test is applicable only for categorical data such as men and women falling under the categories of gender, age, height, etc. Chi-square test relies on approximation. While Fisher-Isaac test is a statistical test used to determine if there are non-random association between two categorical variables. And it does not use randomized approximation like chi-square test. Therefore, remains valid for small sample sizes. For example, if you are studying a certain treatment for skin cancer that led to good outcomes, the first nominal variable is treatment. Some patients are given drug X, others are given drug Y. The second nominal variable is outcomes. Some patients are cured, some patients are not cured. So when a complete study is done, you find that certain percentage of patients who were cured with and took drug X is much higher than the percentage of patients who were cured and took drug Y. So in this case, we can use Fisher-Isaac test, and it will tell us whether the results are statistically significant. Coming to patients' characteristics, the sample size calculation and the power of the study was not mentioned in this study. So during this entire study period, there were 588 infants within the gestation of 24 to 29 weeks in Leiden University NICU, of which 8 were excluded, of which 6 being admitted after 24 hours and 2 being having a major congenital anomaly. There were 293 infants included in pre-implementation cohort, and 295 infants were included in post-implementation cohort. So coming to baseline patient characteristics, since there were no, here we can see there are no significant differences between the baseline characteristics of the two groups. So we can assume that the treatment assignment cannot be retrospectively related to the patient characteristics. However, we can see that the number of multiple pregnancies are higher in both the groups. This has been mentioned as the cause for this has been mentioned as since this Leiden University of Medical Center is a national referral center for fetal therapy. So the multiple pregnancies were higher in both the groups. Coming to outcomes. In the outcomes, there have been no difference in the mortality up to 1 month of age beyond term corrected gestational age. The p-value was 0.81. So there were no significant differences in morbidities also, except the incidence of culture proven sepsis was higher in the post-implementation group. The reason I don't think which was mentioned in the study, and this was only culture proven sepsis, not the entire sepsis. The clinical sepsis, they have not included the entire data of sepsis. Coming to the other outcomes, the other outcomes of IVH, PVL, BPD were also not different significantly in both the groups. However, the length of stay also was not significantly different in both the groups. Coming to respiratory outcomes, the use of minimally invasive surfactant technique for surfactant administration was more prevalent in post-implementation AOC, post-AOC implementation. However, and in the post-implementation cohort, the duration of mechanical ventilation was shorter, and the result was statistically significant. In the post-implementation cohort, the duration of non-invasive ventilation was longer. Here we can see the number of CPAP days in the post-implementation cohort was 13, average was 13. In the pre-implementation, it was 10.8, whereas mean HFNC days in the pre-implementation was 3, and in post-implementation, it was 5.8. Both the results were statistically significant. Coming to supplemental oxygen, the results were supplemental oxygen. The post-implementation cohort received higher supplemental oxygen in terms of number of days. Other results were not that significant. Coming to discussion part. So this study compared two large cohorts of preterm infants admitted to NICU after implementation of AOC. Implementation led to no change in mortality and morbidities in preterm infants despite a shift towards more non-invasive ventilation. The rates of mortality and morbidities were also not very different from the previous study, which had reported short-term outcomes in infants less than 30 weeks of gestation. This was the first study reporting the effect of AOC on clinical outcome in preterm infants, and when AOC was implemented as a standard of care. Using AOC in clinical practice could lead to leftward shift of SpO2 distribution. The reason for this, they have said, is bedside staff would seem to prefer to target the higher SpO2 values within the prescribed range, whereas AOC devices, for the most of the part, they target middle SpO2 value of the target range, potentially leading to lower median SpO2. With the introduction of AOC, there has been a shift towards more non-invasive ventilation in the NICU. They have it may be due to two reasons. Firstly, it might be due to more stability of oxygenation. Secondly, by reducing the baseline oxygen requirement, which can be due to direct consequence of continuous FiO2 titration to target the midpoint of SpO2 range. The limitations of the study was the clinical deterioration might be masked in while using AOC. Since automated FiO2 regulation could result in unwanted reduction in reduction in caregiver's attention to the patient or the individual infant. In preterms, hypoxemia can be induced by number of conditions, and automated FiO2 control could potentially mask such conditions with higher FiO2. For instance, SpO2 for a particular infant may remain within the acceptable range, but at a significantly higher FiO2, indicating the reduced oxygen uptake. So it can be argued that the continual assessment and display of basal oxygen requirement, as well as number and magnitude of interventions by AOC device, could be used as an additional objective indicator for clinical deterioration. The lack of effect on AOC on clinical outcomes can be attributed actually to several causes. Some of them are like some of the outcomes being assessed are relatively uncommon, and the effect size of the study was not that large. It was in fact very small. Hence, there are practical implications of the outcome due to small effect size. Several changes in the study standard of care have been made during study span, which could have simultaneously influenced the outcome in either direction. For example, in November 2014, they had introduced MIST, and the target range was also changed. The lower limit of target range was changed from 85% to 90%. So this might have led to narrowing the SpO2 distribution and shifting it to the right. Another limitation of the study was first was unmeasured factors. Like there have been many factors they did not measure. For ROP, they have not measured liability in oxygen requirement, history of blood transfusion, poor postnatal gains, etc. Various for IVH, they have not measured maternal risk factors like infection, mode of delivery, infant risk factors like platelet dysfunction, coagulation disturbances. For NEC, they have not measured, taken into account HSPDA, UAC, artificial formula feeds for BPD, volutrauma, barotrauma, and many other factors. Being retrospective in nature, this study precludes us from drawing any definitive conclusions like more infants receiving non-invasive ventilation than invasive in the AOC group. This was one more fallacy and one more limitation. And another limitation was that the actual time of infants receiving AOC was not recorded. There was a local policy to disable AOC once the SpO2 values were more than 98% for continuous 30 minutes without any supplemental oxygen. And thus it was possible that some infants only received AOC for a short period, diminishing any treatment effect. To conclude, the implementation of AOC in tertiary NICU had no significant effect on clinical outcomes at the hospital discharge in this retrospective study of preterm infants, but was associated with a shift towards more non-invasive ventilation. Coming to CASP analysis of the study. So the questions are, did the study address a clearly focused issue? The answer to this question is yes, the study was focused in terms of population studied, risk factor studied, and the outcomes were considered. Was the cohort recruited in acceptable way? Yes, the cohort was recruited in an acceptable way. There was no selection bias, and the cohort was a representative of defined population. Was the exposure measured to minimize the bias? We can't tell about the exposure because the objective value of TR kept changing. Initially it was 85 to 95% to 9. Then they have switched after European guidelines of targeted range to 90 to 95%. They had introduced MIST in 2014, and the actual time of AOC was not recorded, as we had discussed previously. Hence, the exposure to the groups was all the groups was not the same. Fourth question, was the outcome accurately measured to minimize the bias? Yes, the outcome was accurately measured to minimize the bias. They use objective measurements and have been validated, and the measurement methods were similar in the different groups. Have the authors identified all the important confounding factors? No. There were unmeasured factors like we have discussed for ROP, IVH, for NEC, BPD, and these factors were not accounted for. Was the follow-up of the subjects complete enough? Yes, the follow-up was complete and long enough to measure the desired outcome. So what are the results of the study? The implementation of AOC, that is automated oxygen control, had no significant impact on clinical outcome, but was associated with a shift towards non-invasive ventilation. So how precise are the results? The results were precise in what it intended to measure. Ninth question, do you believe in results? Again, we can't tell about the results as it is hard to ignore, but it can be still affected by a confounding factors which they have not measured. So hence a better study design like an RCT with blinding is needed to confirm the results of the above study. Can this be applied to the local population? Yes, cohort study was an appropriate method to answer this question, and it considers the subjects which had characteristics similar to the local population. So do the results of this study fit with other available evidence? The answer to this question is yes. They had mentioned, and we have also seen that it has the results were almost similar with the previously conducted studies. So what are the implications of this study for the practice? So this observational study does not provide robust evidence to recommend changes to the clinical practice or within the health policy decision making. Better study design like RCT with blinding is needed to confirm the results of the above study. A large outcome assessor blinded randomized controlled trial is called the FiO2C study is actually underway, which compares the automated oxygen control with manual titration. It is being in the recruitment stage right now. The study was started in July 2018. The last patient after follow-up will be expected in October 2023. With this, so thank you everyone for attending. So we have finished.
Yes. Are there any queries? I don't think anyone posting anything in chat box. So yes, Dr. Nilesh, can we design the study to answer the same question with a different study design?
So as we have discussed, there is already one study going on, like an FiO2C study. We had said like it was a randomized controlled outcome assessor blinded study. So one is that. Other we can individualize each case like IVH patients with IVH NAC and do a case control study for that.
Yes. And in this study, they have considered the automated oxygen control machines of say Oxygeny is SLE and
SLE
Avia
6000.
has and Avia machine, right?
Yeah, it
Any
used
other machine? Any other machine which is delivering such similar automated oxygen control?
Sir, I couldn't find any other machine with such
no, yes, it is not there for newborns as yet, but in adults there is algorithm of automatic. It is a different algorithm of a different company. They are trying it for COPD patients. For newborns, only these two machines provide such facility at this point of time.
This algorithm was also patented by like that University of Tasmania and Royal Hobart, and it has been used standard of care. Like it is a benchmark algorithm for that.
Yes. So, but yes, as you said, we need a larger study and with a better study design. Maybe FiO2C would give us the desired answers with all the bias considered. Any queries, any points of discussion, any participant wants to make here? Okay, I think we have done it in time, and thank you, Dr. Nilesh, for taking out efforts, and
thank you, sir.
I thank all the delegates for attending. Though this is a day of Diwali, thank you so much. We close this meeting. Yes, thank you.
Thank you, sir. Thank you, everyone.